I'm Thomas Baldrick at ASH 2014, joined by a couple people from Mount Sinai in New York right now. They are Erin Demakos, the director, and Dr. Louis Silverman, and we're here to talk about MDS. This isn't just an abstract to you, Erin. This is not just professional. This is personal for you. Talk about why you did this study.
Okay. Well, I was very interested in seeing the prevalence of MDS, where we are in managing patients with the first-line treatment options that are available to them, and just to see practice patterns in general of how they approach MDS and treating these patients, since we've had several drugs approved since 2004. So we started looking at this particular information by looking at medical claims forms, which we call ICD-9 forms, and the coding of how these patients are treated.
So what you found is that things are not where they need to be.
Correct. So when the first drug is approved, just so that you know, it is personal for me because my grandfather was diagnosed with MDS over 20 years ago. There were no available treatment options, and then drugs became available. But from the nursing perspective, it was important to me to make sure that we're educating our patients correctly and appropriately. The nurses are on board with what are the available therapeutic options for patients and how to manage them so they continue on therapy for a long period of time, and also have this information available to them in multiple ways, whether it be the internet or education material.
So what are the key findings of your data?
Well, what was interesting is that in looking at the ICD-9 codings over a 3-year period, 2009 through 2011, there were over 107,000 newly diagnosed patients, which approximates to about 34,000 new patients a year being diagnosed with MDS. So we looked at the information even further, drilled it down to how many of these patients are being treated and how many patients are just being observed. And what was interesting is that over 86% of patients are either being managed by just watchful waiting or having supportive care, which would be myeloid growth factors, transfusions, erythropoietin stimulating factors only. That's a substantial amount of patients not having an active drug, which we know changes the natural history of the disease.
So Dr. Silverman, what's not being done?
Well, what the data showed was that there are about 6,000 patients that are being treated with either one of the hypomethylating agents, azacitidine, decitabine, or lenalidomide. And there are about 21,000 physicians that are treating these patients, which works out to about 2.8 patients per physician per year. So there's a relatively limited experience base for the physicians that are doing the treatments. And this is still a relatively uncommon disease with only 34,000 patients per year. And under optimal circumstances, the recommendations are for azacitidine or decitabine to be given for 6 months worth of treatment, 6 cycles for azacitidine, 4 to 6 cycles for decitabine, but over a 6 months period of time. And ideally, all of the patients should be treated with that amount of treatment unless they're progressing through that, which would represent a relatively small number of patients. So the data showed us that 1/3 of the patients get only 1 treatment cycle and then they're taken off treatment. About 53% of the patients, or less than 53% of the patients, get 3 cycles or less. So the majority are only getting half of the optimal number of treatment cycles. Only 1/3 of the patients get out to the recommended 6 cycles. So what we know from our data is that the maximum negative effect on exacerbating the underlying cytopenias occurs in the first 1 or 2 cycles, and that counts can get better in the subsequent 3 or 4 months following that treatment. And the median time to best response is about 3 to 4 months. So what ends up happening is that patients are getting exposed to the maximum level of adverse event or side effect, yet are not being maintained on treatment to get out to the point in the treatment cycles where their counts would improve and they would get a response. So in essence, we're maximizing the negative effect and not keeping patients on long enough to get the beneficial effect. And then the other effect is in terms of what's happening after patients are taking off treatment.
And 80% of patients are then taken off the therapy. Their prognosis is very poor at that point, to limited to 4 to 6 months, and then put back on watchful waiting. So patients are not even being referred to second-line therapy options, which are still now obviously in just clinical trial development. So they need to be referred to a center that has these particular treatment options open to them to participate in.
So this is a bitter pill to swallow in multiple ways. How do you get the word? And I'm sure I'm asking the question and I already know you don't know the answer, but how do you get the word to the doctors that there are other ways, there are better ways, and that the data proves this is true?
Well, I think that, all of our education has been directed towards patient forums, letting them know this information about the number of treatments that are necessary to see the optimal benefit. We do the same thing for nursing meetings and at nursing advisory boards, explaining that patients just need to be worked through the first 2 difficult cycles as the drugs have an opportunity to work, so the patients will start feeling better after multiple cycles. We have things posted on patient advocacy groups, so I think it's important that we, collectively work together to see what are our best strategies to improve these outcomes, so we're not seeing, these numbers that a majority of patients are not being treated appropriately. Patient advocacy groups encouraging the patients to seek second opinions.
But Dr. Silverman, it's known that it's hard for a lot of patients to even think about challenging a doctor.
Well, I think that from a physician perspective, one of the things that we're always concerned about is the notion of do no harm. And so when you give a drug, you see counts go lower, you're concerned that you're administering a drug that's producing toxicity. Yeah, we've done safety analyses that have shown that the risk to patients in terms of complications with infection or bleeding really comes from the underlying disease and not the treatment, and that if patients are supported through, then the drug can be administered long enough for the good effects to become apparent and their counts to improve. So I think that it is about education and assuring physicians that are using the treatments that if they continue through, that the counts can rebound, that the counts can get better, that patients can get a response. And this is different than the typical oncologic paradigm where you give treatments for a couple of months. If you don't see an effect, you conclude that the treatment is not working and you move on to the next treatment. These treatments are different, and we know that you need to stay the course, continue the treatment for a more prolonged period of time, and ultimately you will see the benefit. And the patients will get through those first 2 months where the low blood counts are made worse, and then in about half the patients, and then the blood counts can get better. So I think it is about education, it is about assuring both the patients and the physicians that the counts will get better and that things are not being made worse by the physicians who are treating and want to do the best for their patients that they can, that they can be supported and the counts can get better and there can be a response in up to a half of the 50% of the patients that are being treated. So some of it's about education, some of it is about creating more of an experience base for the physicians that are doing this treatment and are on the front line of treating these MDS patients.
I commend you for your efforts. I know you've taken on a challenge here, and I'll throw this back to you, your own words. Just stay on course.
Thank you
so much.
Thank you very much.